Open.
Outspoken.
It's ophthalmology off the grid.
An honest look at controversial topics in the field. I'm Blake Williamson.
I'm Gary Wörtz.
Thank you for listening to Ophthalmology Off the Grid. Dr. Arsham Sheybani joins us in this episode to continue our season's theme of surgical horror stories. Listen as he describes the outcomes of his challenging case with our hosts, Dr. Blake Williamson and Gary Wörtz.
All right, everybody. Welcome to another episode of Ophthalmology Off the Grid. We're your host. I'm Blake Williamson. I'm talking with my main man, Gary Wörtz. Gary, the summer was awesome. I'm looking forward to hanging out with you on the beach coming up, and then in London a little after that. We're going to spend a lot of time together.
I know. It's always a treat, man. I mean, it's like, this job is hard, but when you have good friends you can go through it with, it makes it all that much easier. This season, as our listeners know, is about sharing our horror stories, if you will. I think this season for me has sort of provided that camaraderie and sort of feeling like I'm not the only one who goes through these kind of things. Today, we are really excited to have someone who I feel like should have been on the podcast a lot longer ago than this is his first time being with us, but
he always says no. He kept
it's hard to get it
right.
I
would love to see a situation where I say no to one of you guys.
yeah no, but let me introduce you. This is the mystery man, and mystery voice you just heard is none other than our good friend Dr. Arsham Sheybani. Arsham is the residency program director at Barnes Wash U, and good friend, glaucoma specialist, ophthalmologist extraordinaire. Arsham, thank you so much for joining us tonight.
No, this is fun. So glad you guys asked me to do it.
And LSU fan.
Oh, big time. Big time. Blake. Gonna be down there for the Bama game.
Oh yeah, awesome. I got you tickets or whatever you need, buddy.
I know, buddy. I wasn't even gonna ask until I showed up because I figured you'd take care of me. I'm gonna see Blake on his off-roading golf cart modification that he drives around in.
Yeah, I might have to crash that party. But Arsham, as you know, we're talking about our horror stories. I can only imagine, for me, Blake, being a glaucoma specialist kind of sort of fits that category, just like on a good day. No offense, Arsham, but I did not do a glaucoma fellowship for a reason.
At a academic institution too. I mean, that's like a double dip.
It's a double hit. So
double dip in horrendousness. Yeah.
Yeah. So Arsham, give us a little, before we get started, and we'll get into the cases that you've sort of thought of and we can talk about, just give us a little bit of your background, where you practice. We've talked about it a little bit, but just kind of your practice setting, what your day-to-day looks like for those who may not be familiar.
Yeah, I mean, a lot of our stuff is like tertiary or quaternary care. By that, I mean, it's glaucoma specialists referring in. I do mostly, it's half and half glaucoma and then half anterior segment. So like IOL cases, I staff the retina fellows twice a month on their lens cases, as long as it's not like bad, like TRDs associated with it. So cornea, when they want to do stuff, I work with those fellows, kind of one of the big teachers for tube shunt surgeries for the residents. Our whole section's like really good about throwing those. And my philosophy really is, I mean, we have a really nice way that we set up the clinics, the urgent stuff, and our university eye service, that's seen by the residents and the fellows. And so when they're operating, the patient knows that that's their patient. And one of the cases I kind of thought about was a case that I was staffing that even when I kind of jumped in, there was really nothing that we could do to salvage it. And I think it's actually pretty good for your audience. It's not like a typical just only glaucoma specialist type of case,
Okay. Yeah. Well, let's dive into it. How did the patient present? What's the background?
Yeah. So, I mean, I think Eagle study's been great, getting us mindful of doing lensectomies. This was a 60-something-year-old lady, and she initially presented to the ER with pressures that were unreadable on Tonopin. So let's just assume, 70s, 80s. Medicated down, so she was now riding in like the mid to high 20s. The goal was her angle was closed. The other side was actually probably appositional for about 180 degrees. So you knew that this was more of your classic primary angle closure causing the pressure issue. And you have to be mindful of other things that we're not going to get into. But, one side's fine, but her other side now, optic nerve was probably like a 0.85, 0.9. She was 2,400 on presentation, assumed from corneal edema. But then once they got her medicated down, she was seeing around like 2,100, 2,200, probably more from the optic neuropathy because the cataract wasn't that bad.
Right.
So, goal is like, let's go in and take the lens. I'll tell you, like when you look at studies as far as glaucoma stuff goes, when their pressures are high, that's the last time you want to like really get in the eye, right? You want to try to settle it as much as you can with orals, whatever you can do drop wise to get them down. And so we thought we were entering in a reasonable situation.
By the way, before you start, do you
Yeah.
have a cutoff of where, let's say, non-emergent routine cataract surgery, are you checking pressures on people? And is there a point at which you say, you know what, I'm not going to do surgery? I want some guideposts.
No, don't routinely do that. It's been rare, but we've had, at least like two I can remember between fellowship and coming back where they went into angle closure from the pre-op dilating drops. So that's so uncommon.
Yeah.
I don't know. Have you guys seen that?
I've seen it once.
Yeah, exactly. It's so uncommon, but no, routinely we don't. And you're deciding to do the surgery to get the lens out to actually open up the angle, and that was the goal. We were going to do it anyway. As far as a glaucoma specialist goes, sometimes your hand is forced, right? Like there's always going to be a time when you're going to have to do it. And I'll tell you, when you get them down, you're better off trying to get to them, not in a rushed fashion, but in a more timely fashion. At some point, the medicines might wear off and the rest of their angle could zipper shut, and now you're in a worse situation than what you wanted to be. But yeah, so we take her back. Phaco's going perfectly normally. It was with a fellow. They have great hands, great skill. And you start to get a little bit of more posterior pressure buildup. And there's a couple of things that you can do at that time, right? Patient's not having any pain. We take a look. They're not having choroidals. Lens is out. It's just the capsule right now, okay? So we're getting ready for IOL insertion. We take a look in the back, no choroidals. But just the back, it's not deepening much.
You're putting viscoelastic in, viscoelastic is coming out.
Exactly. And you don't want to overpressurize because that'll make it worse, right? You start prolapsing iris with too much pressurization, then that can cause an issue. And so a lot of times you're kind of making the call because aphakia is not the worst thing in the world in that moment if you don't have a deep enough chamber. And you'll be surprised, a lot of times things can really settle out afterwards and the AC will deepen. Probably one of the big reasons why you could have shallowing aside from choroidal expansion in an angle closure patient is that sometimes their zonules aren't great. So there is the possibility that they're in angle closure because they don't have great posterior zonules pulling things back along with their anatomy. And when you look at, there's interesting UBM studies, there is the vitreous zonule actually that connects toward the back, and you see that less in angle closure eyes, and you kind of wonder, is that like a tether? But I bring up the zonule issue because even injecting BSS, that can go posterior and give you just a posterior fusion type of situation. So it's not always choroidals or choroidal expansion. And the AC wasn't shallow. It just wasn't deepening as much of what you expect. So we fill with OVD, the bag fills. So that's the other criteria, right? If you can't get that bag open, like don't shove a lens in there.
Yep.
And either you're going to go in and try to do a vitrectomy to deepen it, or what you're going to try to do is force the issue in there. Well, listen, like I've seen way too many instances of zonules tearing when people kind of force it. So when we get the bag expanded, we're taking a look and I'm like, yeah, it's deep enough. We start putting the lens in. But the problem was that trailing haptic was not tucked. So now you're taking a situation that could have been relatively normal, and now you're manipulating things a little bit too much. So OVD's burping out of the wound. Well, it starts to really shallow then. And right now, haptic's trailing out, AC's shallowing. Take another look in the back, and they're still not choroidal. So I was like, this is probably more than likely aqueous misdirection. I hate calling that, but more malignant glaucoma choroidal expansion. Well, IOL's like 90% in. We got to deepen it. We're very comfortable going in through pars plana. And so since we don't have choroidals, well, we go in through pars plana, through a trocar, do just like a 5-second vitrectomy, deepens things beautifully, okay? So things are deepening beautifully. We think that we're kind of in the clear. Right as they're dialing in the lens, you start to see it suddenly shallow. And now she's in severe pain and the red reflex is gone. So it's more of like a scramble mode. I mean, first thing, you don't freak out. Been a part of like plenty of cases that aren't going smoothly, but close the wound, lens is in there, wound's closed, get rid of like your big incisions, shut them down. There is the potential, if it were just effusive, that we could drain them on the spot and things would settle out. So we immediately go to like a quick choroidal cut down, right? And I'm actually going right around the area of the trocar. And so we take conj down pretty quickly, cauterize very quickly, make an incision about 5 millimeters posterior to scleral spur, and it's just blood. And by that time, the stuff's clotted, nothing's coming out. So when that process happens, it happens. I throw another window in, knowing that we're going to need these things to drain over time. But she went from, let's just say, 2100, 2200 potential to light perception, and it stayed that way. Now, her optic nerve was shot. Like when you think about it, it's like it's a really brutal case. But yeah, it was quite a disaster getting a suprachoroidal hemorrhage during a cataract surgery.
And there was no large wounds too. Like that's the thing is like whenever I would see expulsives and things like that, it was always when you're doing something in common with a PKP, or you had for some reason you had some really huge angle. It sounds like your biggest incision in this patient was 2.5 millimeters, right?
Yeah, I mean, like the routinely 2.4, like you said, and the only other thing is like you do the vitrectomy to decompress, so that could decompress things, but we're really mindful of keeping the anterior chamber pressurized, which should equilibrate throughout the entire system. But I, looking back, think that that was the thing that probably kicked it off, to be honest. You decompress the vitreous a little bit, we get that AC deepening, and maybe we weren't pressurizing enough. I mean, you're using the irrigation, but you know, there's OVD in there. That's the only thing I can think about. Now, they are high risk for these things happening, especially when they start with high pressures. But yeah, the crazy thing was, it was just maybe like, reason why I remember this case, I think maybe like 6 to 9 months ago, where I had to do her other eye because she's essentially monocular. But it wasn't in such an urgent situation, and she did actually really well.
How did you control that conversation? I mean, I imagine like right after the surgery in the first week or two, most patients like, oh no, I understand. I wasn't seeing well before, and you know, I had a big surgery, so I'm sure I'm just healing. At what point did you do you have that conversation with them that no, you know, you're light perception and you're going to stay this way, and here's why, and you know, how do you what are your tips? Because I imagine that you have to talk to patients who don't have vision all like every day, and so
Yeah.
how do you? But rarely is it, you know, in your OR and immediately afterwards, I would assume. So like, how do you? What words and phrases do you use? Do you bring a family member in? What are your thoughts?
You know, fortunately, this lady really knew her situation, because I mean, you know, when they present through the ER, it's already pretty dire. When we talk to them, we literally, I mean, we let them know like these are the highest risk eyes. So fortunately, ahead of time, we talked about it. But it was immediately right after where I told her, I was like, you know, one of the things that we were worried about happened, where you had a big bleed in the eye and a lot of pressure buildup from the back. And there is a chance that it can go well. There is a chance that it doesn't recover. And she was really accepting of that, but you kind of reinforce it. And I think probably around like week 4 to 6. Now it's partly I got to like remember exactly how these things went, but I'm not going to do it like very early on, because there's always hope. I mean, I've seen patients turn around. When I was doing trauma, I had a guy who had his son threw a beer can at him at a tailgate, hit him right in the eye, full, ruptured posterior. He was literally light perception when he came in, and after we repaired the globe, did lensectomy, all this stuff, secondary IOL, he was 20/40 uncorrected. So there is a chance they recover, and I always like, you don't want to take away the hope. But by about a month, you kind of have an idea. You know, the bleeding's gone because we had the 2 sclerotomies done, and the scleral windows were done, and it was open, and we didn't have to go back in and drain her. And her vision just was not coming back. I mean, I think some of it was even like optic nerve stuff from that whole issue occurring, because retina laid out flat, choroid laid out flat. And I told her, I was like, you know, I don't think it's going to recover. She was shockingly okay with it. And I wonder if she just kind of knew like her vision was so bad to begin with, that it was just going to go that way.
You know what strikes me is like kind of a duality of dealing with really, really sick eyes. And I've thought about this before. You know, Blake, in our lives, we're generally dealing with people who are looking for, you know, who are 20, 25 and want to be 2015 after cataract surgery, you know, and it's kind of, you bang your head against the, you know, your desk and think, what, you know, I don't know how I can do any better than I'm doing. And there's a disconnect sometimes, or very commonly. But the duality is, you know, it's very rare that we have a day that goes like this. Right. And so Arsham, I just want your thoughts on this of like, I'm not saying that it's lower pressure, no pun intended, when you're taking care of someone who has already a pretty compromised visual system.
Mhm.
But also the flip side of that is sometimes those eyes aren't recovering, and
Yeah.
that's got to be a lot of stress. How do you deal with that? How do you handle that psychologically just in your own life?
I get asked that because, I mean, there's a lot of people that do what we do, and like even some of our own faculty are like, why do you like taking these cases on? I honestly think like that 2025 eye is a higher pressure stake situation. You're right, like the complications don't happen often, but things are really good for that patient. And when I walk into these like reoperations, especially, right, in my mind, there is less stress there. Like it's more complicated, I guess you could say, but it's a little bit less stress. And I don't know if it's like something wrong with me with how I approach it, but
Could be.
yeah, it could be. But no, I don't. And some of it's like my dad, growing up, he was pulmonary critical care burn unit doc in Baton Rouge. And Blake at Our Lady of Lake, he was the only burn unit doctor for I don't know how many years. He was on call 24/7. And he took care of friends of mine that were in there, like when growing up. And he would come home. We always had dinner together and we would talk. And I was like, man, that's real pressure, like what he's doing. And so, like with that perspective, it's hard for me to ever like think like, oh man, I'm in such a bad situation.
Yeah. You might be built different too. I mean, if your dad was like going through that level of stress,
Yeah,
your level of like what a stressful day might look like could be different than like the average person, if
that's
that's what
fair.
your dinner conversation was.
That is fair. I do tell people this though, and I tell my residents, and we might have talked about this before. I'm like, you get into a bad situation, like you just feel like you are literally in hell, but it's not gonna last forever. The day in the case will always end at some point. It's not forever. And if you think of it that way, like you don't rush through things and you try to give it a little bit of thought, be like, it's not gonna be, I'm not gonna be here forever.
It's like that Tom Hanks meme that's all over YouTube. It's so good. He's doing that one of those actors roundtables where he's speaking to like Shia LaBeouf and Robert De Niro and Jamie Foxx and all these people, and he's talking about how time is your ally.
Yeah.
And if things are bad, if things are not going your way, he's like, just wait.
Yeah.
It's going to turn around. And the opposite is true. When you're the man and you're doing slam dunks, nothing but net, just wait. And so like if anything else, when all else fails, just wait and life will get better. I'm curious about taking on cases like this because a lot of our listeners may not be glaucoma specialists at a academic institution. They may do kind of comprehensive or refractive, and I got burned my first 2 or 3 years in practice because I was like, it was like right in the middle of the early stage MIGS revolution,
Mhm.
and I was taking on tough case
Crazy.
in
Yeah.
my version of a tough case. I mean, meaning like they've got parametric field loss, big old double scotomas, everything, central islands. And I'm like, I mean, it's a slam dunk tube case, but I'm like, no, let me go try to do like a KDB or something, like just to
Mhm.
see, and like every once in a while you would nail it, especially if their
Mhm.
pressure is higher and they got them taking the drops. But, I got burned a few times early on with that where the patient ended up getting worse. I never got any litigation or anything like that, but I just felt really shitty about it.
Mhm.
And it was my dad who actually told me, he's like, man, you're a refractive surgeon. He goes, don't you know, you should never be the last person to operate on someone right before they go blind, right? And he was like halfway
That's what
joking,
Arsham is for.
but halfway serious. He was halfway joking, but halfway serious. He was like, if you see these patients actively going blind,
Mhm.
right, what are you going to do next if your KDB or your Omni fails? I'm like, well, I'm going to send them for a tube. I was like, what if you get? What if you have a complication? What are you going to do? Well, I'm gonna send it to the glaucoma guy. He's like, well, that's my point. He goes, if
Mhm.
you can't fix, the problem,
Mhm.
you
Mhm.
might want to consider it. Do you need to be doing this type of glaucoma surgery? You know what I mean? I mean, you
Yeah.
can say the same thing for cataract surgery that goes
Yeah,
wrong
yeah.
to a retina specialist, but we're taught to do that, right? Like these
Yeah.
are cases that I don't necessarily have to do. So, what do you think about that? I mean, we're always telling comprehensive guys you can do MIGS and you can treat glaucoma,
Yeah.
but like, don't you think that I don't know, maybe when you have like bad parametric field loss, maybe that's a case you want to refer.
Yeah, I'm with you, Blake. I do take like your dad's philosophy where like in general, like when it's in your wheelhouse, make sure you can kind of cover like the issues that'll happen. Aside from like dropping lenses in the back, obviously. I think that's like standard of care. But um uh, when you talk glaucoma, if there is someone that is like pretty accessible and can see patients in a timely fashion, I think it's more reasonable to refer when they have really bad disease or pretty high pressures. But if you're really like the only person around, or like the wait time to get into the specialist is really long, I can't fault people for taking on, especially like a phaco-based case when it's an angle closure case, because even in the best of hands, like things could be really bad, like we were just talked about. And I'll tell you, like all the maneuvers I did didn't change anything, and there's the potential, like you could argue, and that's why I like bringing it up. Maybe you should have left him aphakic. And why did we do the vitrectomy to deepen it to get the lens in? Like we do it all the time, but that's one time when you got burned. Maybe they were worse off in my hands. Like you could argue it either way. And I think the biggest thing for me is access and timeliness of access. And when it's a procedure that you can do, and there's not timeliness and access to get that patient to someone else who might have a few more little bits of training to handle things, I still think it's okay for the comprehensive ophthalmologist to take it on. Now, you're not like shoving tubes in people. We're not talking about that. But phaco-based things, yeah, I mean, and look, like with glaucoma, I tell patients it's the cancer that doesn't kill you, right? Like we're never going to cure it. It's always going to be there with you. You're always treating it somehow. And so you're trying to really save their vision as best as you can. And as long as you're not doing the wrong route, like the procedure itself, if it's picked the right way, yeah, but it's the axial links that get really short and you have to do adjuvant procedures. So when they're less than 19 millimeters, if you're not used to that and doing like a vitrectomy through the iris, through the capsule, like an iridozonular hyoidal vitrectomy, I think then you should refer that. But this axial link was normal, which a lot of these angle closure patients are.
I like how you said, you kind of made it sound like you almost less pressure. It's just less expectations is what it is, because I'll say that from time to time. I'm like, if we do nothing, you're definitely going to go blind. Maybe not tomorrow or next month, but that's happening. I'm going to try something. And so you can kind of take all that pressure off you.
Well, I had, just to add a little, bit of flavor here, I had a patient, and I was pretty big on doing goniotomies, just with a Sinski, sort of like, I think you have the fang or the bent needle technique, kind of similar. And I did this on a patient who was pretty non-compliant. So let's say pressures were in the 30s, came in, we got her back on meds, basically got her relatively controlled. Did the goniotomy without any problems. And then she just did not want to take her drops postoperatively, and her pressure didn't spike, but it went back to like 30s. And she went from having, moderate field loss to really snuffing out within the pretty early preoperative or perioperative period. Nothing abnormal about the case, total, 7-8 minute case. But she went online and pulled articles from some of our colleagues saying that if someone has moderate to severe glaucoma, they should not have a goniotomy because it can cause a pressure spike.
No.
And, I just started thinking like, man, sometimes it's like you're damned if you do and you're damned if you don't. Like, I'm trying to help this person who clearly would not take her drops. That's why she was in the position she was in. I was trying to do something that wouldn't break the bank for her that I felt like was pretty efficacious. And, her pressure went back to its baseline. It never actually went above 30. And, she's, it was not litigation, but it looked like it was possibly a situation. And, she calmed down and we talked to her and, I explained my thought process. What are your thoughts on that?
It's so interesting that you're bringing this up now. I was just working on a talk. And so Rich Parrish, like just phenomenal glaucoma specialist, great career. He presented at WOC, and he presented a case of a patient with like reasonable cataracts and a pressures that were somewhere like 19 to mid 20s or something. Okay, with disc damage, and it was consistent advanced field loss on one side, splitting fixation. He polled the room of glaucoma specialist, and I'm putting this together. That's why I can kind of give you some of these numbers. When the physician is treating the patient, about 24% of physicians would do an angle-based surgery with the cataract, and 45% would do a filter. Another 12% would do a tube. All right, so let's just say about 60% are going to do a subcon surgery, 25% are going to do an angle procedure with the cataract when they're treating the patient. He asked the other half of the room, so he just split the room in half. Physicians answered that first question. When the physician is the patient, Now 45% of them said that they wanted an angle procedure in their own eye, and only, I think, 35 or 40% wanted some type of subconj procedure when they're the one getting the procedure done.
Isn't that
So
interesting?
yeah, because we all know that glaucoma doesn't stop with one surgery. Sure, you can get people out of it, but like you have to play the numbers. We don't live in England or Sweden where trabs work 90% of the time. They just don't. And so
Right.
you can't say that. And like the data's right there.
Right.
Physicians treat patients differently than they would treat themselves.
Right. It's just it's hard when, you know, someone cherry picks one article that may or may not be taken out of context from some person saying moderate glaucoma shouldn't be treated with a
And
goniotomy.
the data's actually kind of looking, I mean, early on where it's probably more longevity of disease. That's hard to tell, but like if they've been treated on drops like 10 years and they're still really mild, I'm starting to have a little less confidence in the angle sometimes than they could be advanced and just recently started on medicine. And
Right.
you see that with other disease states. So I don't know if there's a perfect answer. And yeah, like anything can cause an IOP spike. Your phaco, you could do phaco and not do a glaucoma procedure, and that's your highest risk for an IOP spike.
Do we even know? I know, like, if people are using certain machines that have like IOP, it's not intraocular pressure, it's intraoperative pressure. I don't
Yeah.
exactly know how that correlates to true pressure inside the eye, but do we know actually what pressure is happening inside the eye when we're phacoing? Does anyone know
No,
this? I should
no,
know
and
this.
I think one of the biggest issues is actually how we're taught to do phaco in residency, which is overfilling with OVD. Just that step alone, like the pressure, I see like residents like punching in visco and it's pouring out the wound. I'm like, the eye is literally like 90 to 100.
Right.
when
There's
you
no
feel it.
blood
I'm like,
flow.
feel it right
Right.
now, like
Right.
that. Now it's amazing how rare we have an issue, but I
Right.
think that's more of a problem than like even the machine-based pressures. It's like these really bad high IOP spikes that we induce with OVDs.
Right. It's like a
Yeah,
TI.
I'm with you, Gary. That IOP reading on certain machines, I don't think it's telling you anything. I
Okay.
do like to go low on it though, so
Yeah.
I'll get pretty as low as I can with the chamber being stable.
Yeah. And probably
Arsh,
good research coming out about actually doing surgery at lower pressures. I think that's something that's on the horizon.
Arsham, let me ask you this question. We only got a couple minutes left here, but just my final question, at least to you, is, when I see keratoconus patients, I can walk in the room and I don't have to look at the chart. I don't have to know what's there. I can look at the patient, and just from the vibe, from the experience, I can say, you know what? I bet you this patient may have keratoconus.
Mhm.
And I'm wondering if it's the same, for you sort of anticipating a glaucoma patient that's not going to do so well. Like Ramesh Ayala used to tell me, I just think this one has bad protoplasma. Like he could just almost like smell it or sense it or feel it that no matter what he does, this patient's not going to do well. Like the keratoconus thing, like usually they're wearing like an anime shirt. They have like they could have like funny tattoos, sort of a weird affect. Their hygiene sometimes can be off-putting. Not all of them, but not to
Yeah.
generalize. But oftentimes you see it. I'm like, they almost have a vibe
Yeah.
to them. Can you sense when a patient is going to do poorly with surgery?
There's two ways of defining poorly. One is like their perceived outcome. I think the biggest red flag is when they're wearing sunglasses in the office, in the waiting room.
Yes.
The other one that I can now spot, like you spot keratoconus, is the nanophthalmic patient. When I walk in and you see the lid architecture and how the eye is sunken in, but not because the cheeks are really prominent and the orbit's prominent. It's just the eye is so small. I'm like, oof, this is going to be a rough case. And so that one I feel like I can kind of sniff out more than like another patient. And those are always like higher risk in my mind anyway.
Yeah. My tell is if I ever see a patient, I don't know why it generally all right, I wouldn't even say gender, but anyways, a patient wearing a wrist brace. I don't know why. If I see a patient wearing a wrist brace, it's such a red flag for me. And I know people have like actual wrist issues. I know
It's
that is a
hard.
thing that happens, but for me, I can't. I don't
I
know.
wish I didn't hear that because that is gonna mess me up so much.
You look over the past medical history and it says fibromyalgia, and you're like, okay, I got it.
Or,
Sulfa allergy.
or 10 allergies when like each allergy is like a 1 in 1,000 rate, and they got 10 of those 1 in 1,000 things happening to them. I'm like, yeah.
Yeah. But I feel like compelled to tell you, if you see a wrist brace, just beware.
I'm gonna be careful here.
Yeah, new red flag out there.
Arsham, thank you, buddy. This is
Hey,
awesome.
thank you.
You
Yeah,
gotta,
we love hearing from our friends. Blake, this has kind of turned into the everybody's suprachoroidal hemorrhage story, but it is horror story, so it does kind of fit. So it's no surprise that this is something that stresses us all out. But with that being said, Arsham, thank you so much for coming on. You're always welcome to come back. And for Blake and I, this has been Ophthalmology Off the Grid. Until next time.
Thanks for listening to another episode of Ophthalmology Off the Grid. And thank you to our guest, Dr. Arsham Sheybani. Tune in to future episodes to hear more horror stories from top ophthalmic surgeons.